My name is Beth Davison. I'm Momentum Research in Durham, North Carolina. And the name of our analysis was an acute heart failure as a distinctive disorder and analysis from BIOSTAT-CHF.
My name is Gad Cotter. I'm a heart failure cardiologist and the CEO of Momentum Research.
So BIOSTAT-CHF was a trial that enrolled patients who had either acute heart failure requiring hospital admission or patients with worsening heart failure managed in outpatient clinics. There were about 2,500 patients who were enrolled from the end of 2010 to the end of 2012 in 69 centers in 11 European countries. That was the index cohort. We also had a validation cohort of approximately 1,700 patients who were enrolled in 6 centers in Scotland.
The purpose of the analysis was to try to understand if patients who are admitted to the hospital with acute heart failure are different from patients who suffer from worsening of their heart failure but do not require hospital admission. There has been a lot of discussion in the heart failure literature over the last few years on the topic of whether acute heart failure represents a specific disorder separate from chronic heart failure in the way that, let's say, an acute MI represents a specific disorder separate from chronic ischemic heart disease. Or whether acute heart failure is just an exacerbation of chronic heart failure, something that happens from time to time. In some cases, you get admitted to the hospital. In some cases, this can be managed as an outpatient clinic. But this worsening of heart failures that lead or do not lead to an acute admission were thought by some authors to be representing the same process and not a different pathophysiological pathway. So the purpose of the analysis was to look at baseline characteristics, outcomes, and proteomic profiles of patients admitted to the hospital with acute heart failure and try to see if they are similar or different from patients who have a worsening of heart failure that does not lead to an acute hospitalization, thinking that if they are different, this might suggest that acute heart failure is a different disorder than just worsening of heart failure and has its own pathophysiological pathways that can potentially help in diagnosing it and treating it better in the future.
In order to address the question, we constructed several statistical models, one of which was modeled to predict patient status, that is, inpatient acute heart failure versus outpatient worsening heart failure. And for that, we used logistic regression. Then we also looked at whether the predictors of clinical outcomes in these two patient groups differed. We looked at time to 180-day all-cause death by patient status and time to 180-day heart failure readmission using Cox proportional hazards models. First, we developed these models in the index cohort, so we used all 2,500 patients there. And then we validated the models in the validation cohort. So all of the patients who were enrolled in the BIOSTAT-CHF study were included in the models. Main objective, which was to discriminate between acute heart failure versus outpatient worsening heart failure, there wasn't an endpoint per se. Basically, we were modeling the inpatient versus the outpatient status. The other two endpoints were collected as part of the BIOSTAT-CHF study. And as I said, we looked at these data to see whether or not the factors that predict these outcomes in these two patient groups were similar or whether they were different.
Going into the study, this analysis, if you will, was to try to determine whether patients who had been hospitalized because of acute heart failure are fundamentally different from patients with chronic heart failure that have mild exacerbations that can be treated in outpatient clinics. And the conclusion of the analysis was, by all means, that these two patient populations are very different. First, we found that patients with acute heart failure have a dramatically higher morbidity and mortality during follow-up. The mortality of patients with acute heart failure was much higher than those with outpatient exacerbation of worsening heart failure, and so was the rate of readmissions for heart failure. Second of all, we could find that the proteinomic pathways in the two patient populations have been activated in a different way. There were a lot of inflammatory and vascular markers that were activated in patients with acute heart failure that were not activated in patients with worsening heart failure in the outpatient clinic, suggesting that there could be that an acute inflammatory vascular activation process is the main driver of acute heart failure events that require hospitalization. And thirdly, we have seen that the predictors of bad outcomes in patients with acute heart failure and worsening heart failure were also substantially different. So I think that's this analysis of the BIOSTAT database have went a very, very long way towards resolving the debate that existed, if you will, in the scientific community and among heart failure experts, whether acute heart failure is a specific disorder with its own pathophysiological pathways, or it is just chronic heart failure that went bad. And I think the conclusion is that acute heart failure is indeed a specific disorder that is driven by specific pathophysiological pathways. And those pathways can help us both in diagnosing the patients better, because one can envision a combination of a few biomarkers that can be measured during the acute episode, and that can tell us whether the patient indeed has acute heart failure or not. And also may become therapeutic targets if somebody may develop some therapies that are specifically targeted to the inflammation and vascular processes that underlie it. It's very simple. Acute heart failure is not chronic heart failure that just went bad. If you have a patient that has some mild worsening of heart failure that you can treat in the outpatient clinic with a little bit of diuretics, this patient, although doesn't have a good prognosis, and one has to look into what is going on with the patient and try to verify if there is no other treatable issues that have led to the deterioration, such, for example, of mechanical problems in the heart, uncontrolled hypertension, non-adherence to medications, etc., etc. The outcome of this patient is largely benign. However, when a patient is admitted to the hospital with acute heart failure, this is a remarkable event in the patient's history that leads to massive increase in morbidity and mortality. And the treating physician should be on the lookout that this patient is likely to further deteriorate, and make every effort possible to try to identify what are the reasons for the deterioration and try to treat them if and when it is possible. I think there is a take-home message also to the scientific community that we have not gone far enough in trying to understand better the pathophysiological pathways behind acute heart failure, and therefore our ability to diagnose it, and most importantly to treat it, has remained very, very rudimentary and hasn't changed the last 30 or 40 years. And this needs to be, and a lot of investment needs to go into trying to improve that problem.